Let's do it.
Well, good afternoon, I guess we are now at that point of the day. So I am really excited about bringing this panel together to get this information out. This is, the title of this is, I stole this title from Craig. Craig wrote a blog that said this, but not just for the last days, hospice, the most misunderstood word in healthcare. And I think that's probably true. I think that it's a situation, I know myself personally, I wish I knew what I know now, after getting to meet all you wonderful people. If, my father would have benefited dramatically from the services that you guys provide. We didn't know what it was. Okay. We just thought it was a morphine drip the last few days. And that's, so we missed out on giving he and my mom, who was his caregiver, the benefits that you guys provide. So let's get this thing going. I'm going to go ahead and let you guys introduce yourselves. Tell me who you are. Tell me who your company is, and what your scope of services that your company does. And then we'll go into an open conversation. So Lori, I'm going to let you start because you're the next to me on the screen from what I can see. So I'll let you start.
Thanks, Jim. I'm Lori Wallace. I am a nurse practitioner. I started Life's Journey, and Life's Journey is a concept and a new hospice provider, as far as we give hospice a place. We all call hospice, it's not a place, but hospice can be a place. So we've created this beautiful 20-bed inpatient facility to give an end-of-life experience to the families and to the patient. We think hospice is a specialty, just like cardiology or anything else, and that it needs to be treated as such. We want to enhance the way people are living the rest of their days, because it's not about dying. We all know that. It's about how we're living. So we created an atmosphere where it's calm, and we have hospice experts here taking care of other hospice company patients. We felt like we could all play in the sandbox together. Our hearts are all in the same place. We all want end-of-life care to be phenomenal. Those last days should be memorable in a good way. So we created Life's Journey. We partner with over 38 hospices now to bring these different levels of care. We do general inpatient care. I always felt like, as a hospice nurse, I didn't like my patients being in the hospital. So we've created settings for them that we can give that high level care, intensive type care in a hospice setting. We also offer respite care, and we do private pay as well. So when it does get too tough at home, we're here to take over that burden of the caring for the patient, so the family can be a family. Whether that's several days or several weeks, it's just it's unique to each individual. Our passion is just as such, just to get end-of-life education out to everyone, and to understand there can be a place, and we can all be in the same place together and partnering to take care of that patient with hospice expertise.
Excellent. Craig, I'm going to go to you next. And I full disclosure, Craig's the one that first explained hospice to me the way for me to be able to understand it about 2 years ago. I'm like, oh my God. So, so then I made you write a blog for it. Okay. It's kind of like, okay, say what you just said to me and we'll put it out. So, yeah. So go ahead and introduce yourself and who you are.
Yeah, thanks, Jim. It's a pleasure being here again, and just being a part of the panel. I always enjoy this. And I think, like all of us on this call, and even in healthcare, we enjoy helping and teaching and being a part of people's lives. And so I am with Heartland Hospice and Palliative Care. So we provide hospice service in the home, wherever home is, whether that be home on Main Street that you've had for 30, 40 years, or if that is assisted living or a skilled nursing facility, wherever that may be, we provide those services. In addition to hospice care, we do also have palliative care, and palliative care is kind of maybe that transition for folks who are not quite eligible, do not quite meet Medicare's eligibility guidelines, or who are not quite ready, or who might still be seeking aggressive treatment. That palliative is kind of that transitional in between time, but really for symptom management. So that is what I do with Heartland.
Excellent. So let's go to Allison. As I'm going across my screen, so that's kind of where it is. So Allison.
Well, hi there. I'm so excited to be here. My name is Allison Belcher. I am the administrator for Brighton Hospice here in Indianapolis. And just to piggyback off what Craig said, we offer hospice services in the home, wherever home may be, whether it's assisted living, skilled nursing facilities. in the home setting. And then we also, we actually partner with Lori as well with Life's Journey. And so we've had a couple of patients there as well. And we cover, from our territory perspective, we cover the entire Indianapolis metro area up into Anderson and now into Muncie. So.
Well, excellent. Thank you. So Cheryl, please introduce yourself and who you guys are.
Yes. Hi, everyone. I'm Cheryl with Guardian Angel Hospice. We're a homegrown company. Our anniversary is actually coming up in the fall, and we're proud to have been around the community helping everyone for about 20 years coming up. The company was built with 5 women who were all involved with hospice and just really wanted to support, felt like there was a lack of support to the families. And we feel like just supporting the families just as much as the patients, it's a win-win with education. We're big on education. And we have an aromatherapy program that is very dynamic and unique. And our families and patients feel a little more relaxed sometimes going on service because they can start with that. Some of our patients never go on any pain meds or anything like that, and they really want to truly just stay more naturalistic focused. So it's their journey. I had some experience. My dad passed at 48, so I at 20 was his caregiver, and then my mom just passed 10 years ago. I'm a school teacher, and I got into this for the ministry of it. I felt like it was a God calling, so it's such an honor to go out there and really take the anxiety away from, or at least help with that with the patients and the families. And communication's our big thing. You know, we're very focused just on hospice, but we do a really good job with all the services that come together with that. So just honored to be here today.
Well, thank you for being here.
Yeah.
So let's see here. Chelsea, would you like, you're next on this one as you're going across though.
Well, hi
Thank you.
there.
Hi.
I'm Chelsea. Oh, Chelsea or Chalise?
Chelsea is who,
Great.
At least you're
Sorry.
over here to the right.
All right, so I am the Director of Clinical Services here at Brighton. I work alongside Allie. Brighton is just such a unique hospice company. We provide home care hospice, so just like the others have said, we provide care to those wherever they call home. But Brighton was created by two owners. One is Erin, she's a nurse by background, and Thomas is a marketer that also grew up in industry. And so their major focus is on promoting, really like fostering our team and hiring the very best people in the industry and giving them the support that they need, because we know that when we hire the right people and we give them what they need, everything else falls into place. So we have a huge focus on just supporting and developing our team members so that they can provide the most excellent care possible and really upholding those excellent standards. So it's pretty exciting. We started in Utah about 10 years ago, and we're now in 8 states across the country. So it's been a really awesome journey and just such a great focus on the team.
Excellent. Last but definitely not least, Chalise, I'll let you explain who you are. We have
Yeah,
two in
sorry.
class today.
People have been getting my name wrong my whole life, so I kind of answered it.
Me too.
I bet. So I'm Shalise from Paradigm Health. I've been with the company about 4.5 years. I am an LPN, so I've worked in nursing homes and doctor's offices my entire career. I came to hospice, and frankly, I was a little scared of it at first, and then I realized what we were able to do and the people we were able to help, and how we touched so many lives, and it called to me. So it's definitely my ministry. Paradigm Health was started about 8 years ago. Our owner Jeff Jarecki was regional ED of different nursing homes throughout central Indiana, and he just wanted to make a difference in the way hospice patients were treated. And his first goal is to treat his employees right, and then we go out and treat our hospice patients and other disciplines right as well. We also have home health and palliative care. Palliative care, we're the first palliative care program to be certified in the nation. So we're kind of proud of that, kind of leading the forefront on the palliative care. So glad to be here.
Excellent. Well, thank you for being here, and thanks for bringing up the palliative care, because that also is a very misunderstood and not understood program. So we were actually having a panel on it. I really can't remember if it's a couple weeks away. I'll do that at the end. Explain when it's coming out. I'm doing a panel. Life Co-Pilot's whole purpose is to educate and to get information out from you experts. I try to see if I can talk over my dog. But anyway, so get this information out from you experts to people who may never have an opportunity to hear these things, may not do it. I know that from talking with most of you, one of your biggest concerns is the fact that people don't understand what you do or what's available to people or what they're missing out on. Again, I brought up my own father. He was a situation where we as a family thought hospice was, a morphine drip the last few days, never even considered it. And we had an in-home health, doctor that would come to his house, and he slipped into a coma. So she called hospice, who showed up 5 minutes after he had passed, which I still appreciated because she did the paperwork. But we had no idea what kind of benefits he could have had until I got to know all you guys. And I'm going, oh my God, we've got to get this information out. I don't really care who starts this. I'm going to pick on Craig because he's the one that taught me. But originally 2 years ago, I went, oh, the light bulb went off. What is hospice, and why? It's so misunderstood. But tell me what it really truly is, and y'all jump in on this.
No, I mean, hospice, it's the highest level of benefit that Medicare covers. So, Medicare Part A is going to cover hospitalizations and rehab and home health. But at hospice, the benefit that Medicare covers is our services. And with that, it is such a large benefit, all with the idea to keep the individual at home, make sure they are comfortable and well taken care of. But beyond that, hospice is the only benefit that Medicare also has outside of the individual. So it is for the family as well. So whether it be the bereavement services after or even before a patient passes, to social workers, to chaplains, to the aides and the nurses. So just really kind of being that lifeline for the family in their time of need. They're at the end of life, and end of life is no one knows. Unfortunately, many folks think of hospice as the end of life, which is the last few days, but it's not the case. There are folks who are on for months and even years. And so ideally, I think we would all have those clients that we have that's our most successful ones and that have the best experience are those ones who are on for a longer period of time to really get full use of the hospice Medicare benefit.
Anybody want to add on to that?
And I'll add, we go by hospice Medicare guidelines, and each patient has to have a diagnosis that supports 6 months or less to live. And I always tell families when they hear that they're scared. That doesn't mean that they're going to pass away in 6 months or before 6 months. God knows when he's going to take them home, and when he's ready to take them home, he'll take them home. But we'll be there during that time.
Absolutely. And I think it's important to note that people actually have longer days. There are studies that prove that people actually do have more quality, not only more quality, but more days of life if they do choose hospice care. And I think that's one of the very misunderstood things as well. We're waiting too late to give them those very quality days that actually would help them live longer, as if they continued aggressive treatments and didn't seek out the holistic philosophy of hospice care that truly believes in quality days at the end instead of quantity. But the quantity comes in essence as a result of that. So I think that's really awesome to tell people and to educate people on as well.
Agree. I think a lot of our patients and our families are a little dumbfounded after we have conversations with them, because they're thinking about how hospice used to look. And it's so different now. We have patients that graduate off of hospice several times. I think the extra set of hands with our teams, with all of our companies, they tend to do a little bit better there for a while. It can be an uplifting thing. I talk, we are so focused on and excited and celebrate when someone's born, and there should be the same amount of dignity and respect and really a celebration of someone's life and everything that they've done, and just kind of keeping the family close and the friends and finding unique ways to make them feel even more special and pain-free in every single way, which also includes emotionally. So it's a completely new look. And most of our families and patients are like, what? They can't fathom that, because that's not the picture that they had always known.
Well, one of the things, go ahead.
No, I was just gonna say, a lot of these girls have, and Craig have mentioned how it's about families too. And I think that's what she said about the birth thing. I talk about that a lot. We have a birth story. We need to have a rebirth story. Like we're going somewhere else. Whatever you believe, you're going somewhere else. And how do we make that story wrap up? Because who's left with that story is the family. So how do we wrap our arms around the family and give them that good story going out? Whether it's, with us, it doesn't matter what hospice they are. I don't care. As long as they're here, we're going to help them to create that story as well. So I appreciate everybody saying that about the families, because it's about everyone, not just patient, but the entire team. The one left with the memories will definitely be the family, but how to make that story go well for them. So I appreciated those comments about that.
Yeah, I think it also stems around the sooner that a family or a patient gets involved with hospice and investigates the hospice benefit and chooses a provider and does their research, and they are part of that plan of care that's built upon admission. And so the sooner that they are able to come on service, they get comfortable with their team, they're comfortable expressing needs to the nurse, to the chaplain, social worker, to our CNAs. And so I think that the sooner that somebody does reach out for services, the more benefit that they actually receive, because they are able to be a part of that plan of care, family included.
And to piggyback off that a little bit, I think it's one of the only settings that is so focused on the individual patient and family goals. So we aren't there to tell the patient or family what they should do. We're there to provide education. We're there to provide support. We're there to help identify what their goals are and work with them towards those goals. I think a lot of times there's misconception about hospice is going to come in and they're going to do X, Y, Z. They're going to discontinue these meds. And that's just not the case. We're there to find out, what does this family or patient want to achieve, and how do we help them achieve that? How do we empower them to be able to take care of their loved ones, or to be able to achieve those things that they want to do at the end of life? And we're there to walk with them down that path and not necessarily choose the path that they're walking.
Yeah, I think, Chelsea, to piggyback off that, I always let families know too, like, you're still in the driver's seat. Their family is still making those decisions, and at any point they can, decide that hospice isn't the right for us right now, or whatever it is. They're still in full control, and that's an important thing, I think, for families to remember. They don't relinquish that control when they come on to hospice. So.
Yeah, I think you're right, Craig. A lot of times they think that we're going to come in and kind of dictate what's going to happen. And I always like to say, this is your journey, you and your families, and you have the steering wheel. We're just there to support, to educate, to help you with the anxiety of everything, kind of letting you know what may come next, and giving that patient and the family the best quality time, available. But I agree with you, Craig. That's important.
I will tell you that I have recently done something. I don't know how long I can do this, because quite frankly, it's pretty hard. You guys have a hard job as well. But I got on Facebook and I got into all these groups. I think I'm into a dozen different caregiver groups for family members or what have you, like support groups. And the stress, the depression, the frustration, it tells me how much Life Copilot is needed, okay, to get this information out. And I cannot tell you how many times I've already taken this particular video will be, and keep that in mind, that you'll be talking to these people, okay, because I go in and grab these videos and put them on threads of people that they'll put out this frustration. Oh my God, we just were told we had to put mom on hospice or what have you, and this overwhelming dread and guilt and everything that comes across. They don't know what it is.
Mhm.
They don't understand what they're doing. And then they're sitting there going, well, how do we, they're just going to want to come in and put mom on morphine, and then, she'll be a vegetable till, that's really the perception that's out there. I don't know
It is.
it's
It is.
unbelievable, because I see it every single day on these groups. Okay. So I'm always grabbing these videos and going, here, listen, to what's going on. I'll take blogs that our hospice people have written and go, here, here's something you can get and get some information. So part of this video, it will be used in these roles. I can promise you of that. That's where it's going. So you're speaking to that audience, that you got the audience that is here today, but also the ones in the future that will be getting this promoted to them. What someone said to me early on, that like a light bulb went off, is when I understood that doctors they're designed and trained for curative measures. They are going to keep trying to cure whatever it is that goes on. When you have an uncurable situation, you're not, now you're not going to cure this. Sometimes that curative thing is actually almost torture. It's basically putting them, their body through situations that it's not going to do them any good, but but they're programmed to do cure. Where hospice is designed to treat the symptoms, not the cause, to increase the value of life, the quality of life, and that's why you see people graduate. From what I understand, is all of a sudden maybe they're eating better, maybe they're sleeping better, maybe they're doing things because they're not in so much pain.
Right.
Could you fill us in on that? Because that's when that clicked, all of a sudden the light bulb went off and going, oh my God, I had no idea that's what you guys do. So if you guys would like to fill
that's
that
kind
in.
of piggybacking off of what I said earlier. That, I mean, the studies show that people live longer. But I think too, a lot of people have multiple doctors as well, and they're receiving treatment from so many doctors that they're on a combination of maybe medication regimens, treatment regimens that are complicating their health in general. So I think just coming together with one entity, such as these great people, bring people on, and then we evaluate all that and find out what do we need to do here to give you the best quality of possible without having all the hands in the pot. And I'm sure all these guys would agree with me. It doesn't really behoove us to bring someone on board and just morphine drip them. We want people on service. We want them to. This is our ministry, as she's. I think Chelsea or maybe Cheryl said, is our ministry to do this, and it doesn't behoove us to make it quicker. We're not here to hasten. We're here to soften and soften the process. So definitely doesn't behoove us to just do things like that. We're definitely about quality and comfort for sure. And then getting a comprehensive plan of care, such as the Brighton girls had talked about, to get everything unified and structured so that gives that patient that ultimate comfort and well-being, health and well-being.
I don't know if somebody else wanted to jump in or not. Well, but to me, that's the message that needs to be out there. Getting that word out, getting that information out to the families, that they're not, because what I'm seeing is this feeling of guilt that comes across because they feel like they've thrown in the towel or whatever. And it's not throwing in the towel, it is changing the way that we're tracking things, so.
Yeah, that's the truth. I feel like I'm going one family at a time, teaching them one family, one doctor, one referral source at a time, letting them know exactly what hospice is, because I still have doctors that say, oh, we've got to stop all the medicines. We can't give them antibiotics anymore. Trying to teach them that it's not a scary word. I mean, people hear hospice and they're like, we've got to put them on the prayer chain. We've got to call everybody. We've got a couple days to live. And I've sat with families for 3 hours explaining to them exactly what's going to happen, so they know that we're not going to come in and kill them. I want to put someone on my hospice, on our hospice, so they can live and they can live well. Obviously, everybody's going to die, but I don't want them just to get on hospice so they can die. I want them to live. and have good quality while they are living. And you know, we do get you know, those patients that we're going to the oncologist multiple times, and what their body looks like when we finally are able to get them on service. It hurts me, you know, that they could have had these last days that they have of their life could have been quality, and they were fighting it. They were fighting for their lives, but they could have been on service sooner and been able to kind of do what they want to do, guide the care plan, guide what we do, and guide their life for the days they have left.
And there comes with a lot of stressors. So my family, I'm from the south side of Chicago, and my mother had 4 siblings, and I'm the oldest of 4, and my dad was gone. So it was kind of us, and my mom wanted us directed with her medical care, but the siblings kind of got into the way a little bit and how they thought things should go. And I always speak to my families and patients, you know, everybody has a different relationship with that patient. And everybody should be honored with that specific or different relationship. And, you know, making up a list of, if they're a home patient, like who can help, so that it's not all on one person and there's that strain with family strife. And my family was, you know, very focused on the morphine piece, and mom might have left this earth a little bit sooner because our hospice nurse was doing her job with different kinds of meds. You know, there's so many other meds to use too, other than morphine. So I always say, like, we can take that completely out of it. We never even have to speak that word of morphine. So again, it's just kind of helping the family, guide them, take the pressure off if there's any crazy family dynamics, and just kind of be there to kind of smooth things over, organizing their thoughts with how to proceed carefully if there are dynamics.
I think to kind of piggyback off of that, Cheryl, we do have social workers and chaplains, and I think it's a focus on resources too, right? So our teams are so knowledgeable that they have these resources to help guide family members with issues such as that, right? So say we do have caregiver breakdown, we have options for respite. You know, our social workers have multiple different modalities to get a hold of in-home caregivers and different companies that we can partner with. I think, you know, from a clinical perspective, it is our job to come in and educate on those medications and to give options and to say, hey, you know, in our best clinical judgment, this is kind of what we're thinking, and allow the family to say, hey, yeah, that works for us, or hey, could we try something different, because mom or dad wouldn't like that. And so I think, you know, I've had the opportunity, I've been in hospice for 9 years, I'm a nurse by background, and I've had the opportunity to sit at the bedside of many individuals. But I've also had the opportunity to sit on the other side of it and be a family member. And it's a very different, even when you're familiar with it, it's a very different experience when you sit on the other side. And I think that that's something that, you know, when we bring new clinicians in and we're teaching them about the hospice benefit, or we do re-education with our staff, we're saying, hey, you know, we know that we do this every day. However, this is the first time that this patient has had this diagnosis, and how can we be kind and gentle, yet still be able to provide the education that's necessary to help guide that journey.
One of our viewers, Lynn, just put in a post that she says she agrees with all of you. She goes, I wish she had continued the year before we actually did register for hospice. We waited until the next year, about 8 to 9 months before my mother died. She did not understand the expanded role of hospice. So, I mean, that's very common of what we're seeing. We've got another question here. It says, from Sarah, says, if anyone with a 6-month diagnosis, is anyone with a 6-month diagnosis eligible for service? Does anyone have to private pay, or is it always done by Medicaid? Whoever.
It's a Medicare benefit, and then also private insurance will often cover hospice benefit, but if they have Medicaid primary, yes, it would be Medicaid benefit as well. There should be no private pay costs. I will elaborate on that a little bit. You have to have the 6-month diagnosis that meets the criteria through Medicare of of that disease process. A doctor has to certify a certificate of terminal illness. He has to sign off that says, if your disease progresses normally, that you would probably not be here in 6 months. But that doesn't mean that you won't be. It's not a little stamp that says you've got 6 months till you expire. It's not anything like that at all. And I think someone had elaborated on that. We've had patients on longer for sure. And that's not what we are here to determine. However, your disease process guides that, right? It does cover 100% of certain levels of care, the routine care in the home. It covers 100% of the respite care. So when the family burns out and needs some help and needs a little bit of a respite, that's a 5-day covered stay. Every hospice runs that 5-day covered stay differently. So, but it is a 5-day stay that you're allotted to have every so often, covered 100%, and general inpatient care. So when the symptoms get out of control, where there's pain or wound management that can't be done in the home, there's general inpatient care, and that is covered at 100% as well. So the only thing that would be covered private pay would be room and board. Hospice does not cover room and board unless it's under those certain criteria, which is general inpatient or respite care. And that's been a very misconcepted, it's been a big misconception in hospice, I think, with me having an inpatient facility, just trying to wrap that around, help patients wrap that around their minds, that Medicare does not pay room and board. It pays for the hospice services, the medications, anything that's related to the terminal illness itself, which does not cover room and board. So that would be a private pay thing for most families if they decided that it was just too much at home, if they needed to go to any facility, not just mine in that case. But Medicare will cover 100% of the regular care.
Earlier was talking about doctors not understanding this. In my own situation, the first time we heard about it was when he was in a coma. So what as a family member, as a person that may be the one that needs to hospice themselves, how do they know what if their doctor isn't guiding them because they're not educated? How do they know what to do, and what process would you recommend for people?
I think that's probably our biggest frustration as hospice care providers is the underutilization of our service. A statistic from Medicare says that 52% of people who are eligible never get the service, so they pass away without the service. Of the remainder, about 60% of them pass away within 2 weeks. So, Jim, you asked that question, and we've had this discussion, and it does, and unfortunately, that's where we get the persona of it's the very end of life. I have a good friend who's a physician, a family care physician. He said, well, we've talked about it. He said, well, Craig, I let the hospital kind of initiate hospice, and the hospital does it until it's the very end, and the cardiologist thinks the PCP is following that. So everybody thinks somebody else is having that conversation, and nobody is having it until it is the very end. So, to answer that question, I always let folks know, if you notice a decline, I mean, if any of us get the flu, have a fall, an injury, go to the hospital, have rehab, maybe some home health, we're on an upwards trajectory. But that's not the case for everyone. Somebody who may be elderly, might have many different comorbidities, different illnesses. If there's a slow decline, and just maybe we've reached a plateau and it's just a slow decline, that's when it's time to initiate hospice. But with that, it doesn't have to be initiated by a physician. And that's a big thing we really point out, is that, the families can contact any of us, any of our offices or anything, and inquire about it. And we can talk with them, meet with them, reach out to the physicians, get the order, the records. And like Lori said, then look to meet those, see if that patient meets those Medicare guidelines. So I always encourage families, don't wait for the physician to bring it up. That's a big piece, I think.
I think also just letting the families know that they can call multiple providers and get opinions all the way around. And so all hospice companies have somebody available 24/7 to answer questions. And so just having you call and just say, hey, mom or dad has had this kind of going on. Can I just talk to you about it? And we, as the experts, we can guide you on where you're at in the process, and then, like Craig said, gather records if it's time, gather records and do a face-to-face evaluation with a nurse, and then move forward from there.
Yeah, like we see a lot of different physicians. Some, they've all been trained to be curative, but we have some of our physicians that really are hospice advocates and are wonderful with it. And then, and same thing with our referral sources and skilled facilities. And I just like to, they're very busy, and our jobs, as we know out there, is to make all of our referral sources jobs easier. And so just painting the picture instead of having them pull, the records to see where they're at with everything, really just painting the picture to them, like, has this patient lost weight pretty suddenly, or you've noticed a lot of weight off in the last couple of months, or they're using more oxygen now, or they're, there's just a lot of different quick in your head kind of training them or giving them that information. Like, you don't have to decide if they're hospice eligible. Like, just think about those things. And, if you have any questions, like, let us handle it. We'll see. And if not, that's okay. Like, don't be afraid to, at least, it's so good to educate our patients and families ahead of time. And instead of them needing it a week or two before, and there's so much more fear with that, but educating way in advance, which I know we can all say with our different hospice companies, is our goal, because it's so really sad and disheartening in every way to, see someone that we sign up for hospice services, and then they don't even make it on. They pass the next morning before our admission nurse can get there or whatever. So that early education is key.
Well, and I think it's also just never too early to call and find out. The worst case scenario, the person isn't appropriate for services at that time, but that doesn't mean that we can't have that conversation. They can meet the team, they can talk to us about what it would look like when the time comes and what things to look out for that may help that person qualify for the benefit that they've been paying into, if it's their Medicare benefit. So what we can kind of help the family or even the physician say, if these things start happening, that's a good time to have us come back out and reevaluate. And can we check in with you and see how you're doing in a month from now or a couple weeks from now? I think it allows the family time to, or the patient time to kind of think about it, learn what we can provide, and even if it's before the time that they do come on, it's still helpful.
Well, like, for instance, in my own circumstances with my father, for instance, he had cancer, and he was being treated, and the oncologist made it very clear that if he didn't do radiation, it was the outcome was going to be much more bleak than just dying. It was going to be very, very painful and awful. But then when it came to the chemo, he chose not to do that. So he knew that at that point that he had anywhere from 6 months to 2 years to live. Okay, that type of thing. But you guys were never brought up. There was never that conversation. Would that be something that would be a triggering point for a family? For a family going, okay, well, we're not going to proactively try to cure this anymore. Is that a trigger, or what? Tell me how that would work. Do they call you guys and go, I got questions? Do they ask their doctor about it? Somebody watching this video, what would you recommend?
They could do it both ways. They could talk to the doctor. Typically, sometimes oncologists they're acutely treating, and that's kind of their mindset. They're gonna save the patient. So they can either call the doctor to ask for a referral, or ask for names, or they could do an internet search. And I tell families to interview multiple companies, interview everybody, and get information from every company, and make a good informed decision on who you do pick. But yeah, when you get to that point where the doctor, you're not doing any more curative treatment, we know that his time is limited, because that cancer is not going to quit growing in his body, or the patient's body. It's time to maybe bring some extra help in there, and just internet search. If the doctor won't give you any names, and you can go with hospices, and whatever comes up when you do that internet search.
I think it doesn't necessarily even have to be we're stopping all treatment. I think times when it's a good time to call hospice would be things like we had mentioned before: weight loss, infections, frequent hospitalizations. your loved one is sleeping more, they're eating less, they're disengaging. Maybe they've had pneumonia a couple of times, they're having trouble swallowing now. There's so many things that maybe now they're needing a wheelchair where they were able to walk before, they're needing more assistance with bathing or dressing. All those things may indicate disease progression, and it might be time to call hospice and just see if that person is appropriate at that time. I think anytime that you're seeing some of those declines in functional status or things of that nature, symptom management concerns, pain and anxiety out of control, those are a good time to just research some hospice companies and give us a call, because we can definitely guide as to whether the person does meet for that benefit or whether there are some things that we need to watch and wait for.
I'm going to kind of shift gears a little bit here. One of the things that I've heard said a lot from all of you at different times, maybe over coffee someplace, was people graduating off hospice. Does that mean, okay, I'm just going to be a devil's advocate. Okay, so you got 6 months that's being paid for. At the end of 6 months, they graduate off because they're still with us, or is it because they've gotten better? Tell me how that works.
They could be off within a month. Here's the thing, Jim. I mean, there's no criteria. You have the 6 month certificate of terminal illness, which you can go beyond, or you can also come off and graduate much earlier. So when someone's doing a lot better to where they're showing just continuous improvement, and we look at that as a hospice team and say, right now, are we looking more at palliative type thing, chronic care management, rather than actual end of life? So that doesn't have to be up to the 6. I always tell people this: you can sign a paper and get off anytime. If you don't, if you just decide you don't want this and this is not good, that's the beauty of hospice. You're not married into it for those 6 months. You can decide at any moment whether you want hospice or not. But we're there. We're symptom management experts, so we're trying to help with those people that the girls were talking about that have those symptom issues and everything, and are reaching out for help. But if you're not showing that decline, then that's when we all care plan, and we have meetings about it, and we talk about these patients every 2 weeks, and we try to determine with the patient and family, is this really the right level of care for you? And maybe it's not. But at that point, then you help find resources and everything to make sure that they're treated palliatively, that they're followed, and that they're cared for until that comes around and circles around to that point where they're actually end of life, more appropriate for the diagnosis. But it doesn't necessarily have to be what it is. We want them on a while.
Okay, you decide you're going to go on hospice, your family member is going to go on hospice. What do you lose? Do you lose any abilities to do things? I know you're not going to be going after proactively trying to cure things. Do you lose the ability to go to the emergency room if something comes up? Tell me what's the one thing that would be something people would be afraid of?
I personally think people are afraid of, they're restricted, they're stuck at home. They can't go anywhere, because with home health, I think people who've been on home health get that feeling, number one. Number two, I can't go to the hospital for something else. You absolutely can. You have the ability to be treated for other. I have a patient now that has 2 types of cancer. One of the cancers is a terminal ill cancer. It could probably take this patient within the next 4 to 6 months, but they're being treated for another cancer that has nothing to do with this cancer, and because of that treatment, it's helping to palliate their symptoms. So it's not as black and white as your hospice. You're done. You don't get treatment for anything else. If you have pneumonia, we're going to hook you. We're going to give you IV management for pneumonia if that's affecting your condition as far as the symptom management goes. So I think that's the misnomer that we don't treat anything. That's not true. That's why we have different levels of care. We have general inpatient for those types of things. We're not throwing in the towel on everything you got. We're just saying that there's an illness here that you can benefit from our service, and that we can help manage that around the other things that you might have going on. Because typically we all know that patients have more than one diagnosis. They're going to come to us with a long laundry list of diagnoses most of the time. So being able to know that they can still manage those. And I think one of the other, maybe, I don't know if it was Craig or one of the other ladies that said that we're not going to take you off every single medication you have. It's those types of things, and trying to give patients that peace of mind. But
Well, I think
these public forums help it because, you know, like we we're saying, that the hospitals aren't really, if they don't have a palliative care team, which is becoming more prevalent in the hospital now, which I love, then that education is coming much too late, is what we're all obviously experiencing. Hospice has come a long way in the last 10 to 15 years. And I feel like we're getting ready to evolve into a new era. And I think it's people like us that are continually beating the door down to say, we've got to talk about this. You know, Americans are typically very fearful of death. How do we take that fear component out and make this more of an appetizing conversation for people, that we can take that fear element out, and together as a collaborative group, get the education they need to understand that we're really looking out for their best wellness in those days, whether they're 4 days, whether it's 40 days, whether there's 4 months. How can we make that be the best journey for them
Agree
possible?
with you. And what?
Pardon?
Yeah, I think seeing the old way of thinking is hospice is seeing someone, you know, you picture someone in their bed and they're not able to do anything anymore. And so when I do have the informationals with our patients and families, I really paint the picture. Like, we have some patients that still are going to dinner and movies with their family members, or going to family functions, or they're able to go on vacation. And, you know, obviously it's going to be probably a more laid back vacation, but and we do things to help make that happen. Our team works with the families to make sure that they have enough medications. And so it's their journey. I always say it's your journey and how you want this to go. And we're just there, you know, to support you. So changing that picture in the community is I believe, such a big thing, because it has changed, you're right, in the last 10 years.
Well, I know that this is, you know, just from reading the threads that I'm seeing, okay, I know what people think it is, and it is, and this is why we're doing this, is we're trying to get this out, because a friend of mine's father was on hospice for an ailment that was, you know, it was terminal, and then this was back last spring, and then he caught COVID and was hospitalized with COVID, got over COVID, okay, and he ended up passing a few months later from what he had for his hospice situation. But it wasn't like he was going, well, you know, you're going to die anyway type thing, which is what I truly believe a lot of people believe. Once you sign that saying, I'm with hospice, okay, now we're just going to manage your death, not try to keep you alive no matter what comes up. Do you guys run into that with people when you're out talking to them? They're afraid of that, or is it just something I see on blogs where they don't know you guys are looking?
No, they're afraid we're going to come straight in and start morphine and Ativan, stop all medications, and kill the patient. I mean, honestly, they think that's what we're going to do, and we're not. We're not going to come in and do that. Now, if we come in and we think that patient might benefit, if they're having a hard time breathing and they may benefit from a little bit of morphine, you know, we're going to educate. I think I heard a nurse say like 60% of what she does on a daily basis is educating that family on disease process and what's going on. But yeah, we're not going to come in and just try to kill them. And, you know, that's the biggest misnomer that goes on out there.
Shalise is on it, because I'll tell you, and like I said earlier, it doesn't behoove us for someone to die quickly. And we're in the business to manage these people as long as we can. You know, I don't know why that would be a benefit to any hospice provider to do that. However, we have the expertise for when they do have pain, and I'm certified in pain management. So I always want to tell people, you may not need it yet, but we want to start as least invasive as possible, because if you do, death doesn't carry a natural pain element with it. Dying itself is not painful. It's the disease process that they might have going on that's causing the pain. So it's just educating them that, you know, you may never need those meds. But when you do, this group of hospice companies that you can get involved in, whoever you choose has those experts on board to manage those things for you, so that you're not dying in that misery. We treat our animals better than we do our own humanity as far as end of life. And I think we need to stop being so closed-minded as to the fact that, you know, those things we have things available to palliate and comfort and soften your death, but not hasten it. I've even done palliative sedation here in the building. it didn't, and then that's a hard one to pull, to explain and educate on families. You know, we're not putting them to sleep. We're not doing a suicide type thing. It's not that. It's just like you would go get a gallbladder out. Someone's in the level of pain that only sedating them would help that. So those are all unique things that you know, hospice does have those experts available, but that's absolutely not on our first arsenal. As Shalise mentioned, that's not what we're going after. We're going after using a team of people holistically to bring a ministry and a philosophy of care that says, you know what, let's just ride this out as comfortably as possible and forget all this garbage that you've been piled with and all the burden of going to all these appointments. Because right now we're going to wrap our arms around you and your family, and we're going to make this a really nice ride for you. And as a team, we're going to make sure that happens. And it's just getting that message. And I think more public panels like this is very helpful, informative to the public. As we said, that they're not always getting these conversations from the physician. So.
Well, and I think it's a safe place for people to see them too, because they don't have to, you know, they can sit there and hide and not say anything and still get the information, you know, so.
Yeah.
Mm-hmm.
I was gonna say, we just got a question. How does a family member go about raising concerns with care given, red flags? I don't know if there's more to this question that's unasked yet or not, but I'll let you guys handle that. So, and if there is more to it than this, let me know where it is, because you're anonymous. Nobody knows who you are. So
I would say I always enjoy receiving feedback. So anytime there's a care concern, I would appreciate that family member calling into the office and letting us know, because we can't know how to take care of you better unless we know what you need and what we're not doing right. Everybody's so different. At any time that there is something we need to be doing differently for that patient, for that family, if we're made aware of it in the beginning before it becomes a bigger issue, we're able to resolve that more quickly. And we are here to help you guys really help that patient and that family get through whatever they're going through and make sure they're tailored to what they need. And again, without that feedback, we really don't know how to help you best. And if there is a true care concern where you're not getting the care that they need, I feel like that's something that we as a team would want to know about. That way we can address and make sure it doesn't continue or happen to other people.
Yes, we consider that a gift. And I agree with you. And really just discussing at the beginning about how to communicate. You know, for us, we have a 1-800 number and a triage nurse 24/7 that fields the calls, and everything goes through that number, so we don't lose any communication. And just, you know, finding out what their expectations are, and then explaining what we can do. And if something does go down, because as you know, all of us have had service failures and things like that, but just to kind of, hey, if you're not hearing from the case manager that you want to speak to every Wednesday, this is what you need to do to take those steps. And, you know, again, those things we look at as a gift, to be able to improve, and but knowing that ahead of time is really key.
So so basically, I don't, you know, I don't have a follow-up on this yet, but my assumption is maybe they're saying that they've got a caregiver that they're not happy with, like, or what, at the house. All of you guys would have somebody you could go to over their head, I assume, to deal with that. Is, you know, I'm just.
Oh yeah.
Would that be?
Yeah, most of them can call the main number of any hospice. If they're afraid to talk to the nurse that comes in, they don't want to hurt that nurse's feelings or that aide's feelings, and typically it'll be handled very promptly that day. And you know, it's some people just don't mix with some people, and we want that person's journey to be special while they're here. We want them to be happy, and if they don't like a nurse, they don't like a nurse. You know, and we switch that out for them. But you know, it's their journey. It's what they're wanting for their life, and they're allowed to have those grievances, and we fix them when they happen.
Well, thank you on that. Because I assume that's probably, it very often would probably be a personality conflict, and you could always have an employee that, you know, any of us can have an employee that you go, oh my God, I didn't know they were doing that type thing, you know. So so in any case, that right now we're getting down towards the end of the thing, okay? And it always amazes me, because I'm always wanting to go a lot longer than we do, because it runs out of time too quickly. But here's your chance. understand the fact this video is going to get shared. It's going to get shared into these groups because I do it all the time because it's a comment that I'm trying to educate. So, and then other people hopefully will do that as well. What are you're all professionals this, you've been doing it for a period of time, much longer than, you guys know this world a lot better than I do. Tell me, what would you like to say to someone if you had just a couple of minutes to say, please understand this, that, this is your shot. So go ahead, go for it. So I don't care. So Lisa, you're on my screen big. So go first if you have something you'd like to say.
The thing I like to tell every single family is hospice isn't a scary word. I go around family to family. I think I said this before. I go around family to family and let them know that it doesn't have to be scary. We're not coming in and trying to kill them. It's not that they're going to die in 2 days, or we're trying to do it like it was 40 years ago. Patients got on service 2 or 3 days before they passed away, stopped all their medicine, started morphine and Ativan, and the patient passed away. It's not like that anymore. It's a holistic approach, physically, mentally, and emotionally. We're going to be there, and we're going to be there for the family too. Where we give the patient medicines, we can't give the family medicines, but we're there for that family through all of it. So
I would also tell them that, this is care that you are entitled to. You are entitled to this benefit and you need to utilize it because it's such a wonderful benefit. And I think all of us on the screen would say that we are honored to be present during that time in a person's life and to support the family as well. And so I think just that piece of it is so important, that you are entitled to this benefit.
I like to really sit down with people and say, how do you want to spend, given your last days, how do you want to spend those? What does that look like to you? What do you want from that? And how do we make that happen? But I think it's important to come with an open dialogue, that when someone sits and really thinks about how they want their end days to go, it typically is comfort. You're going to hear that over and over. So let's talk about how we can make that happen, because that's what we're about. We're about comfort. We're about embracing and giving you this opportunity that, like she said, is a benefit to you. But how do you want those to go? And really touching on that reality of how you would spend your last days if you were given that diagnosis. I think about it myself, and I think all of us have that same reality check every day. We have to examine our own philosophy of how we want the end of life to go. And it may be treated till the end. And there are people that want treatment until they can't get it anymore, and that's perfectly fine too. And I think just letting people know we're here for you, and we want to provide these services and help you, but whatever you choose, we're still here for a resource, and we're still here and available to help you regardless if you choose it. But just knowing what you really want in your life and with your health and how you want your life to end.
And I think, in all that, like Allison said, you're entitled to it because you've already paid for it. This is a benefit we've all paid for out of each and every paycheck. And, Medicare is paying for this because, Medicare is doing what's best for them and what's cheapest. And unfortunately, that's what they see. But, we are doing it because we care. And so I would say, don't wait. The most common comment we get from families after we started and after they passed is, I wish we would have done this sooner. So, it's there. Take advantage of the program that's there for you.
I think setting up the stage with 4 words, there is no pressure. Telling them that right away, that this is their decision. And, we're not the perfect hospice company for everyone. I think we can all agree. We all have our different things. I try to have close relationships with other competitors, the marketers, because many times I'll give referrals. It's not in our area that we do. It's medically something that we can't cover. Or they're looking for something, they do a different kind of like pet therapy or something that they're looking for. So I think just I always like to share with my families and patients, and it's such an honor. Look, the right care, the right company that comes out and speaks with you, it needs to feel good right here in your heart. And it also needs to match up here. And if those two things meshed, you're probably choosing the right situation. But again, there's no pressure today. think about it. Call me, text me, ask me any questions that you have. That would be the one thing that I would want to, I think is the most important to set that stage.
That's excellent. Chelsea, do you have anything or?
Yeah, I think that one thing to know is that hospice can coexist with hope. You can still have hope and have hospice. Electing hospice doesn't mean you're giving up. It means that you're acknowledging we can help. We can be there to provide those resources to make this journey a little bit easier. We can't change the outcome of the disease process, but we can change the journey alongside you guys. So just knowing that you can still have hope and be on hospice.
I love that. I something today that I heard, I don't even know who said it now, but I don't think it ever sunk in before that today was that you can go on and off. Like you go on and go, nah, it's not for me. You're not truly signing your life away. You're saying I can make, reevaluate my decision. I think that's a big fear relief too. Someone doesn't have to make a permanent decision in the process. So,
Absolutely.
well, guys, this is awesome.
And they're not stuck with us. Oh, go ahead. Sorry.
No, go ahead. Go ahead.
They're not stuck with us for any number of days. They're not stuck with us for any number of days. If they want to discharge 5 minutes after admitting, they could do that. It's their right.
Well, that's something I don't think that clicked with me until today. So that's good information for people to hear. So just real quick, again, we're running out of time, which I hate, but on here on Life's Copilot, anyone can come in here and you can find the blogs. You can find this video will be under video library. There's a terminology thing, but then for you looking for upcoming events, these panels we do twice a month. Today, obviously, was hospice on the 27th. Since April is National Parkinson's Month, we're doing a panel on Parkinson's. On the 13th, we're doing palliative care because I think that needs to be explained as well. And then we have a hearing and speech experts on the 25th of May because it is hearing and speech month. So I just want to make sure that anybody that's watching this can always go there and find out what's coming up. So there's things that are always on the queue. So guys, thank you so much for coming. Trust me, this information is going to be helpful for people, and I know I'll be using it, kicking it out to people as well. And I'm going to give a video of this to each one of you, so you can use it any way you want to use it as well in your ministries. So thank you all for being here. We will do this again soon.
It was an honor.
Thank you.
Bye-bye.
Thank you, Jim. Bye.